Hi everyone, my name is Vineet Singal and I'm the founder and CEO of Anjana. I have with me Ivana Krajcinovic, who's the Senior Director for Healthcare Delivery at Unite Here Health, which is a union health plan. One of the biggest problems in the healthcare system, as we know, is the problem of compliance, education, and the problem of patient management, disease management. And we often think, we think that the problem specifically is very dire and extremely unaddressed for low-income patients. These are individuals that have a 3 times greater risk of hospitalizations from chronic conditions. They cost about $1,000 more than individuals that are middle or high income to the healthcare system. And in fact, the rates of health literacy and disease self-management are the poorest for these populations, resulting in income more than race, gender, education level being the biggest predictor of a person's health. And this notion that these individual patients are out of our control or can be addressed or can be impacted through technology is a false one. For example, the use of mobile technology is extremely prevalent amongst these populations. 79% of individuals on Medicaid have access to a cell phone. And as the slide suggests, the use of text messaging, specifically SMS, is more prevalent in lower income and less educated populations, and individuals that have below a high school education, for example, use text messaging twice as much as individuals with a college degree or above, and individuals making individuals less than a high school education use text messaging 4 times as much as individuals with a college degree or above, and individuals earning less than $30,000 a year use text messaging more than twice as much as individuals making more than $75,000 a year. And so the solution that we have at Anjana, specifically to reach this population, is leveraging the power of text messaging technology along with a simple, intuitive web application that can empower healthcare organizations serving these communities to provide better outreach, health education, and communication. And we have 4 specific features that I'd like to talk to you about. Appointment reminders are essential because a lot of these individual organizations lose on average $250 for every missed appointment. Medication reminders are critical to ensure medication adherence for many chronic conditions, and educational content that is tailored and personalized for these individual populations that have a very specific set of needs that is very different from the rest of the population is essential to provide the ongoing health literacy and patient engagement necessary for chronic disease management. And for a lot of individual organizations that have group appointments or group-based wellness programs, allowing these individuals to connect after the individual appointment with each other and build community and sustain community over time to ensure the peer support that is necessary for effective chronic disease management is an essential component that we're building into our platform. Specifically, going into goal setting is a potential mechanism, and motivational interviewing and values-based affirmation, allowing Jose, who is a 56-year-old Hispanic individual who is struggling with exercise, allowing him to set goals for himself and be reminded and reinforced and encouraged to meet these goals over time in a way that he's actually culturally relevant and is specific to the literacy level that Jose has, is incredibly important for his specific progression in his exercise regimen. And focusing on things like nutrition and culturally relevant education on stress management and disease management, doing foot exams and glucose monitoring, specifically for a low-income population, is in a way essential for effective disease management for a lot of these. And so our team is focused on specifically solving this problem in a way that is tailored and relevant and specific to these individual patients. And we have trained from a variety of different individual organizations, specifically in ethnography and engineering and design thinking and understanding the individual concern that these patients have before we actually go out and implement. And we've been around for about 1.5 years, but we have received some good success, which has shown that there's really a room for these types of technologies, especially for organizations and institutions that are serving the neediest of our population. And so I want to turn over this conversation to actually looking at a specific example and a specific implementation of what this looks like. I want to turn over the conversation to Ivana Krajcinovic, who I mentioned is the Senior Director for Healthcare Delivery for Unite Here Health.
Thanks, Vineet. So we are a union health plan. Our members are low-income and immigrant hospitality workers, the folks who clean hotel rooms, that sell you a hot dog, the stadium, that maybe work in an airport. Those are our folks. We're separate from the union, but for purposes of this talk, it's sort of the same thing, and the workers kind of see it as the same thing, so we'll just keep it simple. What's important to understand about us is that we're a payer. I've been infiltrated. But we're not for profit. Our money comes from the money that the workers manage to get at the bargaining table. So every penny we put into healthcare is money that could have gone into wages or a pension or something else. So our mission is to make sure that workers have the best quality healthcare at the lowest possible cost so that more money can go into their paychecks. Because for low-income folks, arguably putting more money in their pockets is probably the best way to impact their health. So that's what we try to do. We had a big problem in LA and Orange County. We're 80% Latino, and we found out that 17% of our participants had one or more chronic condition. It was eating up 40% of our costs. We have good health care. People have very rich Kaiser plans. So the problem wasn't that they didn't have access to care. The problem was that they weren't able to really self-manage their conditions and were ending up in the emergency room, in the hospital for reasons that could have been avoided. So we looked around, we found a program called the Chronic Disease Self-Management Program that was developed here at Stanford by Dr. Kate Lorig, 20 years ago. And it's very similar to the culture of the union. You bring a bunch of sort of hopeless, fearful people together, and you teach them about diet, education, stress management, medication adherence, and then they support each other and they push each other and they come up with action plans to start changing their behaviors. And this takes place over the course of 6 weeks, 2.5 hours a week. The workshops are led by people with chronic conditions themselves. And it's been tremendously successful. In a year and a half, we put almost 500 people through the program. And it's having real effects. We then have an additional monthly meeting so people can come back and continue to get the support and the education to continue being successful at self-managing their condition. And our hope is not only that they feel better, but they use medical services only when necessary. We can bring down the cost and also put more money back into their pockets. So sounds great. The problem is that we quickly saw that with the amount of people involved, we were going to have a problem. Unions, basically, for people who don't know, and you're all thinking, BART strike. Unions are essentially about empowering ordinary people to come together and be able to do extraordinary things. And to do that, the union really focuses on building deep relationships. You need to know people's hopes and aspirations to inspire and agitate them to go on strike, stand up to their boss, or in this case, get out of denial and do something about a potentially life-shortening illness, right? The second thing the union focuses on is numbers. We have 2,700 participants in LA and Orange County with a chronic condition. 15 people in a workshop at a time is going to take a long time to make any dent in healthcare costs if we can't get scale, right? So we needed to really figure out how to do something that had brought together deep relationships with big numbers, which is hard to do. You can figure out how to do small numbers in deep relationships or big numbers in superficial relationships. How could you get the other combination of deep relationships and big numbers? The union does this by building rank and file leadership, and we've certainly done that. We have 13 volunteer leaders who now lead workshops and help us recruit, and we've got a couple staff, so still 500 people divided by 15. Leaders, do the math. It's hard to continue to make people feel like you care about them when you got that many people and pool of people that you're talking to. So our folks do not look like Emily. I was really inspired by her story, and I'm watching it. I'm like, oh my God, our people they're not on the internet. They're mostly older immigrants. Their kids might be, but they are on cell phones. So I was like, okay, get with the program. Try to find out if technology can help us. So we got hooked up with Anjana. And initially I was like, look, I'm an old school organizer. I spent 20 years organizing with the union. And I'm like, whatever with this technology. It's all about, one-on-one, personal interactions. But maybe this will help. Maybe we can send them some meeting reminders. Maybe we can send them some encouraging texting. And maybe we can kind of make sure they make their medication. But it's going to be an add-on, right? And Vineet's a nice guy. And, maybe I'll be surprised. But I didn't really expect much more than it dealing with the numbers issue, right? And then we did some testing, and I was pretty stunned by the reaction of our folks. Let me see if I get this right. So here's Santiago. You can tell he does not look like Emily. And these are some of the things that our folks are saying. And you're all smart, you can all read, so I'll just kind of flip through some of these. So Tomasa's a housekeeper. And then finally we have Beatrice, who works at Dodger Stadium. And what comes out here is that people feel like the texting, like that someone cared about them. And so it goes to the relationship issue. And I was like, I did not expect this at all. And so now I had a different problem where I was like, my staff is never going to leave the office. They're just going to be texting people so they feel cared for. So we're now trying to do group chat so these folks can talk to each other. And that's how we can expand capacity. So I'm really excited about this. We're also now expanding to other parts of the country. And the last thing I'll say is I'm hopeful that we can use some of these folks to help start groups in other parts of the country to bridge kind of the geographic divide and allow them to, reach out and provide the support to people, workers like them in other parts of the country. I'll end there.